I think we can move along, and if we can have Dr. Rungold introduce the topic on Tdap vaccines. I'll also, as Dr. Rungold's moving up, just remind everyone that with the October 2012 vote to recommend Tdap for every pregnancy also came with a request that we have updates on safety at each and every subsequent ACIP meeting until such time we have sufficient accumulated wisdom on this program.
Thanks for that, John. So good morning, everyone. I'm a relatively new member of the ACIP, and I've been asked to chair the hepatitis working group, which we're in the process of reinstituting, and was also asked to chair the pertussis working group. But that's been in existence for a while, so in a sense, I'm perhaps the least prepared of the committee members to take that task, but nevertheless. To point out that we have a number of the committee members are on the pertussis working group, in addition to a variety of liaison representatives and consultants, and we particularly benefit from the work of Jennifer Liang, who's really been pushing the committee forward and been enormously helpful as we do our work. So simply to remind everyone that we currently do have several ACIP recommendations about Tdap and TD in terms of use in adolescence and in pregnancy, and in the context of a TD booster for those who've received one Tdap. So these presumably are familiar to everyone. And simply to remind everyone the terms of reference for our working group, in part, the first statement here is basically to review the four existing statements that concern these vaccines and to consolidate them into a single up-to-date document. And we're in the process of doing that, and that will be forthcoming at a future meeting, a fully integrated single document. In addition, we're reviewing new data about Tdap and its use in a variety of settings, looking at the issues of post-exposure prophylaxis in healthcare workers, but obviously a key issue has been the use of Tdap in pregnancy, and so that's really what the focus of this morning's presentation is about. The working group has been doing a variety of other things in recent phone calls. We've been reviewing the situation with regard to pertussis in healthcare workers. We've heard a very interesting presentation about the epidemiological and clinical significance of protactin deficient Bordetella pertussis strains, and some really interesting data about a baboon model for pertussis. But this morning, again, the focus will be on the vaccination of pregnant women, and as John has already mentioned, the fact that there's a great interest in assuring that there are no safety concerns with regard to the use of this vaccine in pregnant women. So to remind you that the context here is that in June of 2011, ACIP recommended a single dose of Tdap for pregnant women who'd previously not received it. Then in October of 2012, the recommendation was changed to a dose of Tdap during each pregnancy, irrespective of the patient's prior history of receiving Tdap. But obviously, in the context of making this recommendation, an interest in assuring that there'd be adequate monitoring of safety and that there would be frequent reports telling us, assuring us that if there are safety concerns, that they're being identified and that they would come to our attention. So basically, this should all be quite familiar to committee members. We obviously have the VAERS system and the Vaccine Safety Datalink system, as well as the CISA project. This morning, we're going to hear presentations from the first two of these, the data from the VAERS system and data from the Vaccine Safety Datalink. There is a study of Tdap safety in pregnant women being implemented in the CISA project, but that'll be the subject of a future presentation. So this morning, we're very pleased to have two experts presenting data to us. Dr. Pedro Moro will give us an update on data on enhanced surveillance in the VAERS system, and then Dr. Elise Carbanda will give us some updated information about safety and coverage data from the VSD system. So thank you both very much for coming. Dr. Morrow?
Well, good morning, and I want to thank you for the opportunity to present this data today. So this is the enhanced surveillance of Tdap safety in pregnancy in the vaccine adverse event reporting system. This is the outline that I'll follow. And well, the recommendations have already been mentioned, and you're familiar with them. The first one on October 2011, the second one on October 2012. Now, Tdap is not approved for repeat doses, and ACIP has not previously recommended repeat doses in other populations. No pre-licensure trials for Tdap were conducted in pregnant women. Now, there was a study, a review done in VAERS for the period 2005-2010, and this was before the routine recommendation. And in this study, 132 reports of pregnant women who received Tdap during pregnancy were reviewed. And in this study, 77% received Tdap during the first trimester. Many of these exposures were inadvertent exposures. In 42%, there was no adverse event reported. And there were no unusual or unexpected patterns of maternal, fetal, or infant outcomes. And the table shows some selected outcomes identified in that study. So the objective of this review is to describe adverse event reports submitted to the vaccine adverse event reporting system of pregnant women or their infants who received Tdap during October 2011 to January 2014 since the ACIP recommendations. Enhanced surveillance was initiated on November 26, 2012. We searched the VAERS database for reports of pregnant women after administration of Tdap. These were women vaccinated from October 11, 2011 to January 31, 2014. And we used certain pregnancy-specific MEDRA terms, MEDRA codes, to look for these reports. And serious reports were classified based on the Code of Federal Regulations if any of the indicated conditions occurred. An exception was hospitalization for a normal delivery. We did not consider that to be a serious report. Now, you've seen this slide, and I'm sure that most of you are familiar with the strengths and limitations of VAERS. I just want to point out some limitations of VAERS, which is typical of passive surveillance systems. Reporting bias and underreporting or stimulator reporting can be problematic. VAERS is not designed to assess causality. There's no unvaccinated comparison group, so we don't know how many pregnant women received the vaccine in the system, so it's not possible to calculate the incidence or prevalence of adverse events. And there's no field for pregnancy in the VAERS form, so it's challenging to search for these reports. We requested and reviewed medical records for all pregnancy reports associated with Tdap. Reports describing maternal and infant adverse events in the same report were treated as separate reports. We queried the reporter or the patient for prior administration of tetanus-containing vaccine. So in addition to vaccination records, we also inquired the provider or the patient herself if they were exposed to Tdap in the past. And descriptive analysis of adverse events was conducted. So in terms of the preliminary findings, this table shows some characteristics of these reports. VAERS has received a total of 90 reports. 22% of these reports did not describe an adverse event. 16% were serious. The main type of reporter was the provider in 38% of the reports. And Tdap was the only vaccine administered in 62% of reports. And you'll note that that most women, 55%, received Tdap vaccine during the third trimester. This slide shows some of the pregnancy-specific adverse events that were reported. Here we see the infant or fetal adverse events that have been reported. The first two conditions, ectopic kidney and hypoplastic left heart syndrome, are major birth defects. Here we see non-pregnancy specific adverse events. Injection site reactions or pain in the arm, pain in the extremity, comprise 50% of these non-pregnancy specific adverse events. But all of these reports were non-serious. None of them required hospitalization, and the patients recovered by the time the form was submitted. And you can see the other non-pregnancy specific conditions reported. VAERS received a few reports of pregnant women who were exposed to Tdap in the past, and this slide shows the adverse events among 10 women with prior Tdap vaccination. On the right column, you see the interval between the current and the previous Tdap vaccination, and it goes all the way from 3.8 years for the first adverse event to 7 days for the last adverse event, the last row. This was actually a pregnant woman that received Tdap in the same pregnancy with an interval of 7 days between the doses. And that was actually a vaccination error. And here in this slide, we see this is actually a comparison of safety data in VAERS before the routine recommendation for Tdap during pregnancy. And that's the data that I already showed at the beginning. And we see on the right column safety data after the routine recommendation for Tdap during pregnancy. And you'll note some differences. First, as I already mentioned, before the routine recommendation, most of the women, or 77%, received Tdap during the first trimester. Again, many of these exposures were inadvertent exposures. After the routine recommendation, most of the women received Tdap during the third trimester. That's 55%. The proportion of serious reports has increased from 5% before the routine recommendation to 16% after the routine recommendation. And there have been an increase in the proportion of certain adverse events: preterm birth, stillbirth, major birth defects, injection site reactions. But these are changes that we expected that they would occur because of the new recommendations. So in summary, compared to the period prior to the routine recommendation for Tdap during pregnancy, we noted the following after the routine Tdap recommendation in pregnancy in VAERS: an increase in the proportion of serious reports, certain pregnancy-specific outcomes that occur after the first trimester, certain non-pregnancy specific outcomes, a decrease in the number of reports describing no adverse events, and most vaccinations occurred during the second and especially the third trimester. Changes in reporting patterns are likely due to the new recommendations, increased awareness, and differences in the trimester of vaccination. In conclusion, no new unexpected vaccine safety concerns were noted among pregnant women who received Tdap. There's a limited number of pregnancy reports with repeat Tdap doses received by VAERS, and CDC will continue to monitor the safety of Tdap vaccine during pregnancy with a special emphasis on repeated doses of Tdap. And I'd like to thank my colleagues at the Immunization Safety Office and other colleagues at these divisions at CDC for their work and collaboration in this project. And I'll be happy to take any questions.
Thank you, Dr. Morrow. Any questions here from, yes, Dr. Reingold?
So just a quick question. It would seem fairly simple to add an indicator on the VAERS form of whether a woman is pregnant or not. I'm just curious if any consideration is given to doing that.
Yes, actually, we are in the process right now of changing the VAERS form. And hopefully, and actually this new VAERS form will have a field for pregnancy, and we may be able to obtain some additional information such as the gestational age, or the LMP, which would allow us to calculate the gestational age. That may take, I don't know exactly when that will occur. It may take 2-3 years, perhaps more. But that's right now what's happening.
And Ms. Hayes.
Yes, Carol Hayes with the American Nurses Association and the American College of Nurse Midwives. I have two questions. Number one, did you calculate the rate of adverse events when you looked at the pre-recommendations and post based on the number of pregnancies that made it to full term? Because your rate of miscarriage in the pre-recommendations is quite high compared to the post-recommendations. So your number of full-term pregnancies is different in your two populations, in your two study groups. So I'd just like to recommend that you look at that data a little bit differently. And my second question is, when we look at the rate of these occurrences overall in all pregnancies, it's always helpful to look at how often these events occur in the normal pregnancy population compared to this population, because most of these adverse events the rate is no different.
Yes. Yeah, actually, what we see here are these proportions are based on the total number of Tdap pregnancy reports received. But these are not representative of the population. So these are not going to, one shouldn't think of this as and compare it to the background rate in the population.
Right, no, but I'm recommending that you do compare it to the background rate.
Oh, yes.
Yeah.
Thank you.
Another quick question. I imagine with the VAERS reporting, you're receiving the brand-specific vaccine, either of the two Tdap vaccines, and I'm assuming you're not seeing any differences between the two.
Oh, you mean Acellular? I mean the different brands?
Exactly.
I haven't. We can look at certain adverse events by brand, but to be honest, we haven't really looked specifically. Most of the reports are Acellular reports, about 57%, and about a third are from Boostrix. But we haven't seen carefully at the safety data by brand.
Yes, Dr. Raleigh.
I just have a quick question about, I believe you said this and it went by so quickly. So do we have a sense of how many women got flu vaccine and Tdap at the same time out of this population? I believe I heard you say that they got another vaccine. I'm assuming you're talking flu.
You mean another vaccine on the same visit?
Another immunization.
Yeah, well, the most common vaccine given along with Tdap was TIV, was influenza vaccine, about 21% of reports.
And any other questions? Yes, Dr. Herman.
I guess the other thing that would be helpful, if you know the trimester that the vaccine is given and you know certain adverse events in a fetus occur at a certain developmental phase of pregnancy, if the vaccine was given in the third trimester and something happens in first trimester, you know that's not from the vaccine. So when the various problems are reported, that would be nice to tease that out.
Yes. Yeah, actually, we provided, I mean, for these reports, for example, here we see for the two birth defects, we provided that information in the slide. For example, for the first one, the patient was vaccinated at 17 weeks. And yeah, that's right, 17 weeks beyond, organogenesis has taken place already. So, but for the second one, it was very early in the first trimester.
And Dr. Duchin.
Thank you for monitoring this and for the presentation. I assume you've done more than you've shared with us this morning, and I'm wondering if the numbers that you've shown for the various conditions for women who've received Tdap in the third trimester are any different from those who just received TIV alone without Tdap in the third trimester?
Well, from are you referring to the current? Well, we haven't looked at. Excuse me. Just to clarify, you mean the safety of TIV versus the safety of Tdap, or?
Yeah, because the concern, I think, was that there would be some unique potential adverse event associated with the administration of Tdap, to women repeatedly in the third trimester. So, and we believe influenza is a very safe vaccine. It's been recommended for administration as well. So I'm just curious if the spectrum of, adverse events that are being reported for Tdap are any different than that, which is reported for those among women who receive just TIV in the third trimester.
Well, for TIV based on previous seasons, and actually on this current season, I can tell you that for some of these adverse events, it's comparable. For example, for TIV, I can tell you with certainty that the rate of that we see here for spontaneous abortions is similar between TIV and Tdap. And if we compare it to previous seasons, it's very comparable. We don't see something that would something of concern.
Well, Dr. Shukat?
Yeah, I just want to remind folks that the VAERS data doesn't provide rates. What the analysts are doing is looking at proportion of VAERS reports that have a particular condition. I think it's really helpful for the committee to suggest to the safety office types of analyses with this passive data that would be useful. They've primarily compared before and after the pregnancy recommendation proportions, but we're hearing suggestions for comparing current era, influenza only, influenza plus Tdap, and so forth. But I think the next presentation of the Vaccine Safety Datalink will help provide information about rates, because the point of VAERS is just for signal detection, and I think it's hard for us to get our arms around that, because of course we want more interpretable data, but that's the next presentation.
Thank you. I have Dr. Plotkin, Dr. Moore, and Dr. Reingold.
I'm troubled by the fact that 45% of women are receiving TDAP before the third trimester. This is not influenza. The vaccination is, in the case of influenza, of course, you're trying to protect the pregnant woman. In this case, one wants passive antibody to be transmitted to the infant. So vaccinating in the first or second trimester is not deriving the maximum benefit from the vaccination. It seems to me that the recommendation should be stronger for third trimester vaccination than for early. And also the issue of confusion with congenital anomalies, if the vaccine is given in the first trimester, could damage the idea of safety of vaccinations during pregnancy. So again, it seems to me the ACIP should emphasize vaccination during the third trimester.
Dr. Shugat.
Yeah, again, I just want to point out that you can't look at these data and know what trimester women are getting Tdap in. These are reports of adverse events and what the circumstances were, but this is not the denominator of when women are getting vaccine in pregnancy. So I think the comment about trying to make sure they're high antibody levels at the time of birth is important, but we shouldn't assume that 45% of the Tdap doses are being given before the third trimester, because that's not what this VAERS can tell us.
Dr. Moore?
Thank you. I am glad Dr. Schuchat clarified the issue that this is just looking for signals and is a hypothesis generating system. And we are already seeing questions come to me in my state about, now that we're striving for as many pregnant women as possible to receive Tdap and flu, how are we going to deal with adverse event reporting? Because then during pregnancy, almost anything is going to be temporally associated with administration of those vaccines because of the narrow windows in which they are given, and then adverse events occur naturally during pregnancy, and that correlation is going to be a challenge. I'm wondering if there are any signals in the VAERS data that you've seen that you think warrant further attention based on the data you've presented here?
Well, if we just look at VAERS, we haven't seen any signal. I mean, this is what we've seen. Of course, we'll continue to monitor these adverse events.
Dr. Rengel?
Well, again, my question is not specifically around VAERS, but I note that at least on one of the slides that several women had received a Tdap fairly recently before the dose in question. One was apparently an administration error because she'd received the dose 7 days before, but another one had received the dose 29 days before and the other 159 days before. And I admit I don't know this, but I am curious whether there's some minimum which is given in the recommendations that if a woman has had a dose in some certain time period that she doesn't need yet another dose during pregnancy, and if not, whether we need to think about that. But, so even if she's had a dose a month before, she's supposed to get another dose.
Just for clarification, I think that is the recommendation, that it is for a dose during pregnancy, preferably between 27 and 36 weeks, and it is a little bit fuzzy whether or not you received a vaccine at 35 or at 26 weeks. What you should, unless someone can clarify that for me, but that's, yeah, Tom.
Sure,
Dr.
yeah.
Clark.
Right, so it's one dose with each pregnancy, preferred in the third trimester with the 27 weeks. So yes, you shouldn't, I mean, it would be odd to discover that she was pregnant in the third trimester 7 days after the previous dose, but the recommendation would still be one dose, even if a little bit too early.
Dr. Karen.
So just to follow up on Stan's question, do we have a mechanism for, VAERS is not it, but is there a mechanism for us to know when in pregnancy women are getting vaccinated?
Next talk? Oh, Dr. Schuchat.
I mean, the next talk will be giving you the detail of a managed care population denominator numerator, but in addition to that, we are periodically doing national surveys of Tdap coverage, which would include timing for those who are pregnant. That isn't going to be done annually at this point, but we'll be periodically updating that information. We had to not show the presentation yesterday on adult immunization, but we recently reported the National Health Interview Survey of adult immunization, and that's one of the ways that Tdap in adults is monitored. It's only one time point so far on that, but there'll also be data monitoring through PRAMs and some other systems.
Okay, I think we are ready to move on to Dr. Corbana and presentation on the VSD.
Hello, thanks for inviting me here to share our work that we've been doing on Tdap safety and Tdap coverage during pregnancy from the Vaccine Safety Datalink. So I plan to cover two topics in this talk. First, I'm going to present updated estimates on Tdap coverage during pregnancy from our 7 Vaccine Safety Datalink, or VSD sites. And then I'll present data on Tdap safety during pregnancy from our large observational cohort. To start with, this slide shows the VSD sites that contributed data for our study. All 7 sites shown on the slide contributed coverage data, while the 2 California VSD sites contributed data for the safety study. And that's because for the period covered for the safety study, majority of vaccination was occurring in California. For our cohort, pregnancies were identified from electronic health record and administrative data using an automated validated algorithm. Using our standardized VSD vaccine files for pregnant women in our cohort, we pulled all vaccines starting in 2005, continuing through their pregnancy and up through 6 weeks postpartum for each woman. For our coverage data, then the Tdap vaccines were assigned as being either pre-pregnancy, during pregnancy, or postpartum in accordance with the slides shown here. For our safety study, in order to reduce the likelihood of misclassification of exposures, we excluded women who received Tdap in the 7 days following their last menstrual period, and we also excluded women who received Tdap within 7 days of delivery. So many of you may have seen previous data from our group, as coverage data up through 2011 for Tdap during pregnancy was presented at the June ACIP meeting. So today I'll be presenting updated estimates for pregnancies ending between January 1st, 2007 and November 15th, 2012. The cutoff of November 15th is to allow up to 6 weeks of postpartum observation. As I mentioned before, pregnancies were identified using a validated algorithm. The algorithm identifies when the end of pregnancy was and what the birth outcome was, and then using that, we estimate the pregnancy start date. And receipt of Tdap came from our VSD vaccine files, which basically are coming from electronic health record data. So the data I'll be presenting in terms of coverage reflects both the 2010 California Department of Health recommendations and the 2011 ACIP recommendations, which were to administer Tdap to women who had not been previously vaccinated and preferably after 20 weeks gestation. So this is our first slide showing our coverage data. This slide shows all pregnancies that we identified from all 7 VSD sites for the period 2007 to 2012. And I've bolded the lines that I thought were most notable. So first, we identified nearly 400,000 women with pregnancies ending in a live birth. And across all the study years, 9.5% received Tdap during pregnancy and 14.4% received Tdap postpartum. Moving down and looking by year, we can see that the first increases in Tdap coverage in our cohort started in 2010 when about 9% of pregnancies received Tdap during pregnancy. That increased to 17% in 2011, but decreased to 13.7% in 2012. And the reasons for this decrease should be clear on the next slide. So this slide's similar to the last, except now we're looking at pregnancies ending in a live birth and specific to the 2 California VSD sites. And here you can see that starting in 2010, coverage during pregnancy increased to nearly 16%, was 30% in 2011, and decreased to 19.5% in 2012. But we believe this is due to the fact of a marked increase in pre-pregnancy receipt of Tdap. So in 2012, more than half of pregnancies in our cohort at the California sites had already received Tdap, and so consistent with recommendations at the time, they didn't receive another dose while they were pregnant. And this slide is similar to the last, but now we're looking at live births from the other VSD sites, so the sites in Minnesota, Washington, Oregon, Colorado, and Wisconsin. And here you see the first real increase in receipt of Tdap during pregnancy occurred in 2012, when 16% of women received Tdap during pregnancy. And again, you see more than half of women identified with pregnancies in the cohort had already received Tdap pre-pregnancy, and another 10% received Tdap postpartum. So in summary, for the California VSD sites, Tdap coverage increased substantially in 2010 and 2011, but decreased in 2012, likely because many women had received Tdap pre-pregnancy. For the Minnesota, Washington, Oregon, Colorado, and Wisconsin VSD sites, Tdap coverage increased in 2012 with approximately 16% of women vaccinated in pregnancy, likely in response to the 2011 ACIP recommendations. So now I'm going to switch gears and present data from our safety study. So we conducted an observational cohort study with pregnancies with live birth outcomes, and the outcomes were between January 1st, 2010 and November 2012, and then this is specific to pregnancies at our 2 California VSD sites. Women were required to have continuous insurance enrollment starting 6 months prior to the start of pregnancy, continuing through pregnancy and through 6 weeks postpartum. We excluded women with multiple gestation pregnancies, women with no medical care during pregnancy, and women who received a live virus vaccine. We looked at a total of 4 safety outcomes. 2 were late pregnancy complications and 2 were birth outcomes. The late pregnancy complications were identified from diagnoses or ICD-9 codes occurring at medical visits. We looked at hypertensive disorders of pregnancy, and this was a composite outcome that included a new diagnosis of gestational hypertension, preeclampsia, or eclampsia. And then our second pregnancy complication was chorioamnionitis. And while these ICD-9 codes have been shown to be valid, in order to increase specificity, we required both eclampsia and chorioamnionitis to be inpatient diagnoses. Our 2 birth outcomes were preterm delivery and SGA, or small for gestational birth. Data for these outcomes were pulled directly from the electronic health record. Gestational age at delivery was based on the clinician assessment at the delivery, and we used a single cutoff for preterm delivery as birth before 37 weeks gestation. For SGA, we also used a single cutoff of being less than a 10th percentile weight for gestational age. In our models, we adjusted for multiple covariates with the use of a propensity score. The propensity score was created with logistic regression to estimate likelihood of receiving Tdap during pregnancy, and the variables included in the score are shown on the slide. We also adjusted for site and for receipt of other vaccines in pregnancy. Our analytic approach varied by outcome. First, I'll talk about the hypertensive disorders. For that outcome, we specifically looked at women vaccinated before 20 weeks gestation and compared them to all unvaccinated women. And the reason for doing this was twofold. In the current analyses that I'm presenting, this is not a matched cohort. So we had no way of assigning an index date to the unvaccinated women, and we wanted to make sure that all vaccination occurred prior to the outcomes that we were studying. A second reason is that although hypertensive disorders of pregnancy by definition are diagnosed at 20 weeks gestation or later, they're thought to be due to insults that occur earlier in pregnancy and relate to abnormal placental growth. For these outcomes, we compared rates between vaccinated and unvaccinated women using a Poisson model with robust variance estimate. Next, I want to talk briefly about how we evaluated risk for preterm delivery. So anytime you're conducting an observational study looking at vaccination and preterm delivery, there's a huge risk for bias because women who deliver early have less time to get vaccinated while they're still pregnant. The strategy we employed to try to reduce this bias was we only looked at women who were vaccinated before 36 weeks gestation, and then we used a time-dependent exposure Cox model. For the other 2 outcomes, chorioamnionitis and SGA births, we looked at all women who received Tdap during pregnancy and compared them to all unvaccinated women, and we used a Poisson model with robust variance estimate. And just to note, when I say unvaccinated, I'm just talking about Tdap. These women in both groups could have received flu vaccine. So this slide and the next show baseline characteristics for our cohort. So we identified 26,224 women who received Tdap during pregnancy and had a live birth delivery versus 97,265 unvaccinated women, meaning they didn't receive Tdap. As you can see, most vaccination occurred in the 2nd and 3rd trimester. Most women were between 25 and 34 years of age. And without any adjustments, our groups were pretty similar in terms of age distribution and race ethnicity. This slide also shows additional baseline characteristics. Of note, women who received Tdap during pregnancy were slightly more likely to have adequate or adequate plus prenatal care index. Of note, they were much more likely to receive another vaccine during pregnancy, and this most likely was flu vaccine. We didn't look specifically at whether it was the same day as Tdap or a different day. And then of note, 45% of unvaccinated women and 4% of those receiving Tdap during the current pregnancy had also received Tdap prior to pregnancy. And so this slide shows our preliminary results. Just to orient you a bit to the slide, the first column, Tdap in pregnancy, shows the rates for each of the outcomes among women who did receive Tdap during pregnancy. The next column is showing rates for women who did not receive Tdap during pregnancy. And then the final column shows our relative risks, and these are adjusted again for site, for receipt of other vaccines during pregnancy, and for our propensity score. So from the first line, you can see for chorioamnionitis for the full cohort, 6.1% of women who received Tdap in pregnancy were diagnosed with chorioamnionitis versus 5.5% of unvaccinated women. And that gave us an adjusted rate ratio of 1.19 with the 95% confidence interval 1.13 to 1.27. In contrast, for preterm delivery, we saw that rates for preterm delivery were lower in women who received Tdap during pregnancy, and the hazard rate ratio was 0.88 with the range 0.83 to 0.93. And we saw really no significant differences in rates of SGA birth between vaccinated and unvaccinated women. On the next row for hypertensive disorders, we look specifically at women who were vaccinated before 20 weeks gestation, and 8.2% of women had a new diagnosis of a hypertensive disorder versus 8.0% of unvaccinated women, which gave us an adjusted rate ratio of 1.09 and a range 0.99 to 1.20. And then the final three rows, we looked in secondary analyses at women who were vaccinated between 27 and 36 weeks, consistent with the current preferential timing for Tdap vaccination. So for this subset, for chorioamnionitis, we saw 5.6% of vaccinated women and 5.5% of the unvaccinated group had a diagnosis of chorioamnionitis, so adjusted rate ratio of 1.11 with the range 1.03 to 1.21. Again, for preterm birth, we saw reduced risk associated with receipt of Tdap, so hazard rate ratio of 0.83 and range 0.77 to 0.90, and no significant differences in rates of SGA birth. So I'd like to speak a little bit more about chorioamnionitis. So it's thought to be due to, it's an acute process and thought to be due to polymicrobial infection of the amniotic fluid, fetal membranes, placenta, and or uterus, and is normally diagnosed during labor in up to 8% of full-term deliveries and 30 to 40% of preterm deliveries. It's an important outcome as it can result in adverse consequences for mothers and for infants, most notably as a risk for preterm birth and cerebral palsy. And there are many known risk factors for chorioamnionitis that are shown on this slide. Most prior studies of vaccine safety during pregnancy have not evaluated chorioamnionitis as an outcome. However, in a study that we recently published looking at influenza vaccine during pregnancy, and this was published in September in Obstetrics and Gynecology, we did include chorioamnionitis as an outcome. And so in that cohort, among women who received influenza vaccine at 20 weeks gestation or greater, we reported an adjusted hazard rate ratio for chorioamnionitis of 1.08 with a range of 1.02 to 1.15. For that study, we had conducted multiple comparisons, and so we had set a priori a threshold for significance of 0.005, so that finding was not considered significant. In summary, receipt of Tdap during pregnancy was not associated with increased risks for adverse birth outcomes. The chorioamnionitis findings merit further discussion and possibly further investigation. It's important to note that the findings persisted after our adjustments, and we were able to include some risk factors such as maternal age and comorbidities in our propensity score. However, data was not available for most important chorioamnionitis risk factors. It's also important to note that the actual magnitude of the risk we detected was small. And also, although I wasn't able to show the data, that the risk was largely attributable to differences in rates of chorioamnionitis that occurred specifically in 2012. So it was a single year. And finally, chorioamnionitis is a major risk factor for preterm birth. However, we did not detect an associated increased risk for preterm birth. I'd like to acknowledge my Health Partners VSD team who worked to get this data together, our CDC collaborators, and then the other VSD investigators who collaborated with this work. And I'm open for questions.
Thank you very much for the presentation. I see Dr. Dushan's hand up.
Thank you. During 2010, 11, 11, 12, there was a Bordetella tsunami that was striking the West Coast. And there were huge outbreaks going on in California and then moving north to Oregon and Washington. And I'm just wondering how that and the associated exhortations from public health officials about vaccination and all the press about, pertussis epidemic in the community may have impacted the data that you shared with us, and what, if you have the opportunity to look at data in communities that aren't in the middle of large-scale epidemics, what we might see.
Dr. Liang asked me to pull up the data by site for all the VSD sites. The numbers are pretty small, but we did see increased rates, increased Tdap coverage outside of California, Oregon, Washington. But again, the numbers are pretty small.
Dr. Shugat?
I wasn't, it went a little bit fast, so I wasn't clear whether you mentioned that you couldn't look at these other factors or haven't yet had a chance to, but I was wondering if you have analyzed the data adjusted by first pregnancy or not. Thinking about the managed care populations and that half of your non-vaccinated had previously gotten Tdap, I just wondered whether they were often second pregnancies and the vaccinated are first pregnancies, and first pregnancies are at higher risk for prolonged labor and so forth. So
that's a really good question. So the way that our data comes, we have each pregnancy as a unique data, unique row, a unique data point, and we are not able to link women to prior pregnancies. So we don't know for each pregnancy if it was their first or if they'd been pregnant before. It's possible we have requested sort of additional pregnancy files within our VSD files, but it's not easily retrievable right now.
Right. So just, I guess in the future for pregnancy-related analyses, I think it may be worth getting some input from obstetricians and so forth about what are key parameters. These risk factors that you mentioned, some of them are difficult to get on a medical record, but some, like number of pregnancies, is on every single labor and delivery file. So
it is in the EHR. It's not in our standard VSD files, and we've been working to expand them so that we can get at some of these. Yeah.
I have Dr. Kemp.
I had two questions. First of all, these are all about live deliveries.
Yeah.
Do you have any information about pregnancies that did not result in live deliveries? That's number one. And the second one is I wanted you to talk a little bit about the rationale for the choice of your safety outcomes. They sort of seem somewhat arbitrary to me, and I wondered if you could talk a little bit about that. Thank you.
Sure. I can pull back. The only data that I have on spontaneous abortions and stillbirths is really just the coverage data. So only 1.2% of women with a pregnancy ending, and that includes spontaneous abortion, stillbirth, and therapeutic abortion, receive Tdap during pregnancy. And we don't expect those numbers to increase much, given that the current recommendation is to vaccinate late in pregnancy. So there haven't been that many exposures. Again, with the way our data structure works, it's much harder for us to time a pregnancy for these outcomes. We base most of our gestational age on the clinician assessment at delivery, which is well validated. For these other outcomes within our files, it's hard for us to know whether it was a stillbirth at 20 weeks, a stillbirth at 30 weeks. And so it's really hard for us to know when the pregnancy started or whether the Tdap was really when the woman was pregnant. So right now we don't feel comfortable doing further analyses until, using the current data files.
Ms. Hayes?
Yes, Carol Hayes with ANA and ACNM. I was curious, choreo, as you mentioned a couple of times, is a link for preterm birth, but you did not stratify the data by gestational age at birth and full-term pregnancies with choreo and preterm pregnancies with choreo. Have you done that? Can you do that?
We can do that, and I believe we should. We haven't done that yet, but that's a good suggestion.
My second question is, what made you pick choreo? It's such a bizarre thing to look at with a vaccine.
Yeah, so that was Dr. Kemp's other question that I didn't get a chance to answer. So the outcomes that we picked, we tried to focus on sort of important outcomes in terms of women's health and infants' health. And these are outcomes that we had also studied previously with influenza vaccine. We felt comfortable that we knew the variables were in, the diagnoses were in our data, and there's been some validation work on the outcomes. I do agree. We have an OB consultant, Dr. Heather Lipkin, who's at Yale University, and she's been part of our study team. And she did bring up, I think, what your point is also, that in maternal fetal medicine, often choreo's on the pathway for preterm delivery, but not considered an outcome in itself. I think we were sort of trying to look at what common diagnoses that occur in pregnant women, and it is a common diagnosis.
I have Dr. Campos-Alcalt, Dr. Sawyer, Dr. Riley, and Ms. Pellegrini.
I have a comment and then a question. Comment is, as time goes on, we're going to be very interested in repeat vaccinations and repeat pregnancies. So we need to start thinking about that design.
Yeah, that protocol's already been written and is being led by CDC investigators.
And then the question is, why, I didn't understand why you picked a P of 0.005.
That was for our other study on influenza vaccine safety during pregnancy. We had nearly 80,000 women who received TIV during pregnancy and 300,000 who did not. And we had about 20 to 25 different comparisons. So we were really worried about error if we used a 0.05 cutoff.
I agree about the 0.05.
Yeah.
I'm just questioning the 0.005. I think most people in that instance, if you have 20 variables, would go to 0.01, in which case the finding would have been significant.
Okay, Dr. Sawyer.
Mark Sawyer with the Peds Infectious Disease Society. Could you just clarify your comment that you felt the risk of choreo was largely attributable to differences in rates of chorioamnionitis in 2012? Do you mean in the BSD population as a whole?
Yeah, so within our data files, so I presented this data last fall at the VSD annual meeting. At that time, we only had 2010 pregnancies from 2010 and 2011, and there was no increased risk detected at that time. We added the 2012 data in January, and that's when we found, and when we looked by year, it was mostly due to differences in chorioamnionitis diagnosed in 2012.
Including in unimmunized?
Excuse me?
Including in unimmunized women, that the rate of
No, the differential, that there was a bigger differential between vaccine and unvaccinated women just in that year.
Okay.
Dr. Riley.
So I hate to beat on chorioamnionitis, but it's probably the worst diagnosis in obstetrics ever because it's a clinical diagnosis. And as a practicing obstetrician, I can tell you that if a mom gets a fever, she may or may not have any tenderness. Who knows? She's in labor. She's going to get antibiotics and she's going to get a diagnosis of choreo, and that's what's going to be on the medical record. So, and it's a real tough one because those of us who have tried to peel it apart, you know, depending on how many people get an epidural, you're going to have more diagnoses of chorioamnionitis, right? Because 15% of women who get an epidural are going to get a fever, you know, 8 or 12 hours into it. So I just think that it's like probably the messiest diagnosis there is, and it's really hard to make any sense out of, you know, what it really means. And I feel like it's one of those diagnoses where you need all of those factors, and then there's more risk factors under there, you know, anesthesia, et cetera. So I'm not sure what I would do with that information, to be quite frank.
Yeah, no, I appreciate your input. Yeah.
Ms. Pellegrini?
Back on slide 4, you had a bar that showed the definition of Tdap timing during pregnancy. And it says you excluded women who had received Tdap within 7 days of the pregnancy, which I assume means regardless of when pregnancy. So would that capture a case where, for example, a woman got her Tdap at 29 weeks and then had a preterm birth 5 days later?
That woman would have been excluded. I can tell you we only excluded about 300 women because their vaccine was within 7 days of delivery. The reason we did these exclusions is once a woman's in the hospital, all their vaccinations may show up in our records on the day they were admitted to the hospital, even if it was really administered postpartum. And it's in order to make our data cleaner and make sure that it really was a pregnancy vaccine and not a postpartum vaccine.
And maybe others can just help me understand, could that have masked actually a serious safety?
Yeah, I mean, it was very few women who we think their vaccine was in that window.
Dr. Herman?
So just back to chorioamnionitis. Sorry. I mean, I just wonder, is there any biological plausibility there to even, think that either with influenza vaccine or with Tdap? I mean, I guess I'd ask our ACOG. So I guess I'd maybe suggest, different outcomes looked at. But then a comment, because we haven't talked about this, is the low rates of Tdap during pregnancy that we saw in these slides. And I can tell you that we did a survey of California birth hospitals this fall. We asked them on a single day to ask every woman delivering that day if they received Tdap during pregnancy. We tried to do it before they would have probably gotten influenza vaccine. We didn't validate it, so take it for what it's worth, but it was about 25% stating they had received Tdap. To me, that's very disappointing. And anecdotally, we've heard that many women are being, if it's mentioned at all, it's being mentioned that go get it at the drugstore. And we know how that often works. You might have the best intentions, but there's not follow through. And I know ACOG's done a ton of work educating their providers about this, but I still think it's not being offered as often as it should be. Certainly there are some women who won't accept it, but I think it's got to at least be offered.
Dr. Bennett?
Thank you. I just had a question about the decreased rates of preterm delivery. That sort of suggests to me that there's some uncontrolled confounding. And I wondered if that might be related also to the diagnosis of choreo, and if you could comment on that.
I think that at our site, we believe that most likely the preterm delivery and the reduced risk is still just bias that we're not able to eliminate in this observational cohort. If you think about it, women who delivered at 24, 25, 26 weeks weren't recommended to get Tdap based on current recommendations. They're all going to, end up in the unvaccinated group. Similarly, as you get closer and closer, they just have less time. And even though we tried to adjust for that, you can't fully adjust for that bias. We've done a lot of work on this with influenza vaccine, and we just keep seeing that whenever you have a recommendation that's supposed to happen towards the end of pregnancy, you get this bias in observational studies. For influenza, we really didn't see it for first and second trimester vaccination. But the bias, then you would think you'd get less choreo because choreo is so much more common in these preterm deliveries.
Dr. Relly.
So I just have to put in a plug for OB because I think, we're looking at 2012 and I'm hopeful that 2013 will look better. I mean, as someone has said, ACOG has put a lot of time and energy into increasing the rates. I have unpublished data from my own institution, which looks at February 2013, so a short time. And our vaccination rate for Tdap was 81.6%. Now, obviously, that's in an institution where there is a vaccine champion. But I think that practicing in a very big place, I think that shows you that with persistence, you can actually get there. The interesting thing that we found in our data, even though we got 81.6% of women, we had low rates for African American women, which was very disappointing. We did have a high correlation with those women who were willing to take influenza vaccine were the same women who were willing to take vaccination with Tdap. So, we'll see where this goes, but I'm very hopeful because obviously our numbers didn't look that great in 2012 either.
Thank you so much for that comment. Dr. Duchin started out talking about the tsunami of pertussis in California, but I'd also argue that seeing rates of vaccine coverage during pregnancy in the other sides jumping up from 2% to 16% was kind of a tsunami of providers coming on. That's an eightfold increase in a year, which is incredible. I'm curious about comments either from AAFB. We've already heard from ACOG and from the nurse midwives about acceptance within your organizations.
So Jamie Lair from the AAFP, and yes, the family physicians who do obstetrics are also trying to push Tdap in pregnancy.
Yeah, this is Carol Hayes with ACNM. We actually have a grant from ASTA right now to increase vaccination rates among pregnant women that we see and to improve the perception about vaccines among nurse midwives.
So Dr. Ernstein, we're interested in your comment and also about anything you can tell us about initiatives from NVAC.
Two issues. One, I want to raise something that you had mentioned. We keep lumping Tdap together, but there are differences in formulation in the antigens, quantity of antigens. So I'm wondering if you've tried to look at whether there are any differences between the available Tdap preparations.
We haven't yet, but we can look into that.
And the second issue I want to reemphasize is that NVAC is taking this on as a major effort. It includes, as I mentioned earlier, the desire to have a ACIP pregnancy issue so that it makes it easier for people to just go to one place for all of the issues on pregnant women. And there are major focuses in it. I presume we can get it distributed to everybody in March when it goes out for comments. And again, we're trying to finalize the recommendations at our June meeting, but they cover topics such as enhancing communications, maximizing obstetric provider recommendations, improving financing for services, linking to electronic health records, and dealing with issues of vaccine liability. So again, this is not Tdap oriented, it's vaccines ACIP recommends for pregnant women, and the maternal immunization working group, after this is finished, will take on the issue of how to incentivize development of more vaccines that could be used for dealing with issues that affect pregnant women or young newborns.
Thank you much for that comment. And just for follow-up to NVAC, Dr. Pickering was kind enough to send the draft maternal immunization working group report out to all the ACIP members. So everyone has had a chance. And I'll also again point you to, I believe it's basically page 21 through 20, or 20 through 22, which deals with things at ACIP. I see Dr. Salisbury back at the microphone.
Yes, David Salisbury, United Kingdom. I do have an overwhelming sense of deja vu washing over me, because I believe it was at the June meeting last year that I presented exactly this topic with 20,000 pregnant women collected through a database where all health details were available. We looked specifically at stillbirth rates. We looked at prematurity. We found nothing. We also were able to look at efficacy and found extraordinarily high efficacy in women who were vaccinated between 28 and 38 weeks of pregnancy. And many of the questions that you've just been asking were answered in that presentation, whatever it was, 8 months ago. So perhaps I could just remind you that you do have those slides, you do have that presentation, and the report is in the minutes of your meeting from, I think it was June. Thank you.
Thank you for that comment. Any other comment at this point? Thank you so much.